Functions of pulmonary surfactant. Pulmonary surfactants are substances the body makes that reduces surface tension in the lungs and keeps them from collapsing. According to Sherwood, alveolar cells, the tubes in the lungs, create pulmonary surfactants, which are composed of lipids, also known as fats, and proteins. Because pulmonary surfactants are not developed in the womb until later in pregnancy, premature babies that are born experience neonatal respiratory distress syndrome, also known as RDS. The premature baby's immature lungs will not be able to create enough pulmonary surfactants, which will make it more difficult for the body to inflate the lungs during breathing. Additionally, the absence of surfactants makes it challenging for the lungs to expand during the subsequent breath, since they collapse after each exhalation. The baby's body will experience less strain when given surfactant replacement therapy. This will enable the baby's body and muscles to unwind so they can build up their strength to grow and develop as they should. The infant can stop receiving surfactant replacement therapy after their lungs have fully matured and are capable of producing their own pulmonary surfactants. Infants who are born prematurely often have respiratory distress syndrome, RDS, due to type 2 pneumocytes immaturely being developed, which starts producing surfactant at about 20 weeks of pregnancy. This means that surfactant production is insufficient at that time. Surface tension and pulmonary compliance are both negatively impacted by the lack of surfactant. As a result, there is a higher chance that the alveoli will collapse during expiration, which is followed by a decrease in both the total surfactant area available for gaseous exchange and the alveolar capillary diffusion capacity. Hypercapnia and hypoxia start to develop. The gestational age of a newborn at birth is inversely correlated with the risk and severity of RDS. In fact, RDS was thought to be the primary cause of premature infant mortality before the development of surfactant. As a result, a lot of work has gone into the treatment and prevention. In the past, there have been many potential therapeutic approaches, but few have demonstrated significant success. The introduction of a surfactant is one of the treatments. Since the 1960s, trials have been ongoing as the surfactant product has gradually improved. Randomized, controlled trials have conclusively shown that surfactant replacement therapy significantly reduces the risk of or treats RDS. Due to surfactants' advantageous effects, development and research into novel surfactant analogs have increased. There are now primarily two subtypes, natural and synthetic. Natural surfactants, often known as surfactant derived from animals, have a morphology that is comparable to that of human surfactants. Because natural surfactant is more successful at imitating the activity of human surfactant, It has traditionally been regarded as the superior kind. Pigs and cows are two of the animals employed in these techniques. There are three natural surfactants that are frequently studied. First, minced porcupine lung has been used to create poractant. Second, meractant is an extract from cows. Third, another bovine surfactant obtained from bronchoalveolar lavage is called calfactant. The difference in value between the two categories is still not entirely clear, but the most frequently utilized samples are those from cows, followed by those of pigs. Despite the encouraging results, there are a number of disadvantages to using natural surfactants, including their high cost, variable performance, potential for anaphylactic shock, and potential for pathogen contamination. The pathogenic hazards have not been pinpointed on a clinical level, which is significant to mention. Synthetic surfactant has made tremendous strides in recent years, to the point where it is now competitive with natural surfactants. The invention of synthetic surfactants that contain proteins has been the main contributing cause. Cholecalciferol palmitate, the most frequently tested protein-free synthetic surfactant, was the only phospholipid-only component of previous synthetic surfactants. It has been established by natural surfactant had a superior therapeutic effect. But scientists now have a fresh opportunity to increase our understanding of synthetic protein-containing surfactants, like leucinactant, whose action is thought to be at least as effective as that of natural surfactants. The surfactant therapy against RDS, also known as the STAR trial, compared protein-containing surfactants to natural surfactants. It was randomized, double-blinded, and at the phase 3 trial. 22 centers in Europe, Canada, and the United States recruited 252 very preterm newborns whose birth weight ranged from 600 to 1,250 grams, and who were born between 24 and 28 weeks gestation. Within 30 minutes after delivery, leucinactant or poractant alpha was given. The mortality rate in leucinactant at 28 days was lower than in poractant. Respectively, that would be 11.8% versus 16.1%. According to the results, at 36 weeks of post-menstrual age, patients receiving leucinactant therapy also showed lower mortality rates at 16% versus 18.5%. Similar numbers of serious negative effects were recorded in both groups. These would include periventricular leukomalacia, intraventricular hemorrhage, air leakage, oxygen desaturation, and bradycardia. They did a follow-up research on the subjects a year after the trials were completed. A high follow-up rate of almost 98% was attained. This also means that 1,517 out of the 1,546 were found. For lucinactant, colpoceral, and baractant, the mortality rates that counted loss to follow up as a death were 28.1, 31%, and 31% respectively. Lucinactant and poractant had mortality rates of 19.4 and 24.2 respectively in the analysis of the STAR trial, which included loss to follow-up as the cause of death. Mortality rates with lucinactant and poractant were respectively 18.6 and 21.9%. Compared to animal-derived surfactants, lucinactant reported higher one-year survival rates, although there was no discerning numerical difference. The scientists came to the conclusion that in the therapy of preterm newborns with RDS, lucinactant can offer an equal or possibly higher survival rate than animal-derived surfactants. There are still problems despite the surfactant's effectiveness in the prevention and treatment of RDS being well documented. These include the type of surfactant as well as the delivery method and time. Natural surfactant is currently the preferred surfactant, while it is still up for debate whether subtype may be the best. The creation of synthetic surfactant with peptides that replicates the function of surfactant proteins, however, has shown that they are as effective as natural surfactants, if not more so. In the future, it is believed that synthetic surfactants will be able to replace natural surfactant, producing a dependable, tightly regulated product that will be more affordable and reduce the risk of immunogenicity. The synthetic surfactant, called lucinactant, contains peptides that resemble ones in humans. Regarding the method and time of surfactant administration, early installation of the substance had a stronger impact on lowering the risk of RDS and the difficulties connected to it. The ENSURE method is gradually evolving into accepted practice in the treatment of RDS. The technique, known as nasal continuous positive airway pressure, or NCPAP, is one of these. According to one study, the introduction of NCPAP resulted in a 1.5-day median decrease in intubation time and 23% decrease in intubation rate. Recent studies have shown that this strategy, together with early selective surfactants, appear to provide a better choice since NCPAP has become the first line of care for RDS. Although endotracheal tubes are routinely used for installation, non-invasive procedures such as aerosolized forms have been tested as well.